Bryn Whitney, Branch Manager and Vice President at Bangor Savings Bank. Bangor Savings Bank has been supporting our local communities for over 172 years, and we are proud to partner with MaineHealth Lincoln Hospital for this 5-part series on coastal medicine in Lincoln County. Bangor Savings is proud to work with Lincoln County Television and MaineHealth at Lincoln Hospital. We hope you enjoy this 5-part series as much as we've enjoyed supporting it. Thank you and enjoy.
So, good morning. I'm Cindy Wade, President at Lincoln Health. Thank you for being here on this beautiful summer, well, almost summer, right? Summer day, but feels really summery out there. This is a fantastic space to be having this talk series, and I want to thank the YMCA for allowing us to use it. I also want to thank LCTV for coming in and filming this, so you all will get to see this firsthand, but then others will also get to tune in and hear what we have to say and what Dr. Hunold and Jeff Slack have to talk about. I also want to thank Bangor Savings. As Bryn said, they are partnering with us to sponsor our doc series, which is really great, and we look forward to more of these. We're having another one later in the summer in the Damascotta area, and if these are successful, we will continue to do this. So it looks successful so far with so many people turning out. So let's turn to our guest speakers here today. So Dr. Rob Hunold is one of our primary care physicians, and Dr. Hunold practices here in Booth Bay at the Family Care Center, which is fantastic. So thank you to Dr. Hunold for being here. And Jeff Slack works for Access to Care, better known, I think, to most people as Care Partners. It's a program we've been doing for, and you'll probably talk more about this, but it's been a couple decades now. It has. Working on this. Yep. And I remember when we first started it. So lots to talk about between these two gentlemen, so I am going to let them take it away. So thanks for being here.
All right, thank you. Thank you. Well, good morning, and thank you. We just flipped a coin, and I lost. So I'm going to start off, and I'm the opening act for really the star of the show for Jeff, who's going to really let you know on some really important information. So my name's Dr. Rob Hunold. I've been with Lincoln Health now for 17 years. I live in Noblesboro. I've been practicing primary care in Damascotta for the last 16 years, and then the last year I've been down here in Booth Bay Harbor, because apparently the sun is always shining in Booth Bay Harbor. The water's better, the boats are better, and I'm learning from the natives about how much better Booth Bay Harbor is. So I'm glad to be down here. I've had many jobs over 17 years. Currently, I am primary care most of the week. I'm also medical director of Cove's Edge Senior Living, which is on the Damascotta campus, and I'm also medical director of our palliative care department. I was the hospice medical director for 12 years here at Lincoln Health. I've been directors, I think, of every other department here at Lincoln Health, but that's what I do now. And I was asked to come talk to you about hospice and palliative care, what's the differences, what does it mean, and then questions and answers, which I think we'll probably do question and answers at the end. Before I talk about hospice and palliative care, I think it's important to think about where each of us come from when we hear those terms. Those terms are actually quite loaded terms. People think of different things when we say hospice and palliative care. When I was working at Maine Med for a couple of years doing palliative care, there were actually people who asked us to tape over our jackets. Like our jackets, our white coats would say hospice and palliative care, and they didn't want us to come talk to their loved ones about hospice and palliative care because it had this, whatever your preconceived idea of what that is, they didn't want their loved ones to think of that way. We didn't do that, by the way, because we don't hide things, right? We're going to be honest and transparent, but that's an idea. So how did this young, good-looking guy get up at Booth Bay Harbor to talk about end-of-life care? And where do I come from with regards to my thoughts? Because I have to often keep my ideas on end-of-life in check and not to project them out on the people that we're providing consults to, because that's not fair to do. But I was raised by my mother, who was a very stubborn West Virginia hillbilly, proud West Virginia hillbilly. And she was raised on a very poor farm in West Virginia. She was one of 11. And so death and dying was as real as it comes. People die, animals die, we talk about it, we plan on it, and that's how I was raised. It wasn't taboo to talk about dying. As a matter of fact, Her advanced care plan, and we may talk a little bit later about advanced care planning, but there are various ways you can plan for your end of life. Hers was written on a hammer, on a napkin. I asked her one day, Mom, could you just please write out what you want us to do? She wrote one word, hammer, hammer. Well, could you explain what that means, Mom? Yeah, Robert Neal, when I say enough's enough, I want you to come in and hit me over the head with a hammer. That's it, hammer. Okay, hammer. So, of course, as you can imagine, I told my mom, I said, Mom, we're better at it than that. We can kind of go at this better. But that was her whole idea on healthcare. She did not trust doctors, didn't want to go see a doctor. She didn't see a doctor for 45 years, by the way. And end of life planning for her was hammer. So that's my upbringing. Death, dying, end of life, hammer. Second is, I used to be a Navy pilot. I was very blessed to fly for the United States Navy. And I was on a run with my wife, and I collapsed, not knowing that my heart was in a non-life sustaining rhythm. I was rushed to Maine Med. I was eventually externally defibrillated back to life. And now I have an internal defibrillator in my chest that's gone off twice. So technically, I've kind of been defibrillated back to life 3 times. Well, I tell you what, when you're 30 years old and you're a Navy pilot and you think you're invincible and you get defibrillated back to life, you change, right? You are faced with mortality and you start thinking about end of life. And so I started talking with my wife at the time. She's still my wife now. And I started saying this is how I want things to go. I started thinking about, if I do die, let's do this. And so that's the second experience that I had that made death and dying very close to me and very real. So then I decided I was discharged from the Navy, went to grad school, then went to medical school. And during my medical residency, I was trained at a very large hospital in Phoenix, Arizona. And in that hospital, the hospital has a system of different codes with colors associated with them. So in a hospital, when they announce code blue means that there's probably somebody in cardiac arrest, and there's going to be a team of people that are going to respond to that room and attempt a resuscitation. Now, so as a resident, I was in charge of the code blue team when we would have code blues. So I probably have responded to hundreds of code blues during my 3 years of residency, where a lot of experts descend on a human being and do things to this human being to try to get their heart started. Many of you, probably maybe none of you, have seen how this goes. It is not good. It is brutal. It is chaos. It is large bored needles and defibrillations and everything, all intended to bring the patient back. But when it's all said and done, by the way, the survival rate at our hospital for that was about 20%. The survival rate on the street, by the way, if somebody goes into cardiac arrest, is about 3%. Most people do not survive. And what happened was, after numerous times of doing this, I became very disenchanted with the healthcare system at the end of life. Because at the end of all this, code blue would be a person who has died and they're by themselves in a bed with all sorts of things attached to them. And I kept thinking to myself, where's the family? This isn't their whole life, and it ends like this? 103-year-old woman ends in an ICU bed by herself after a code blue. This can't be the way that this is supposed to be. So my director said, I want you to go work with this organization called hospice. It was the first time I ever heard that term ever in my life. I was 33 years old, never heard of hospice. And so I got a chance to spend a few months with Hospice of the Valley in Phoenix, Arizona. And I'm going to tell you right now, I got to experience deaths that were more magical than births. You can die in a way, if all the pieces fall together, and it could be very magical. It could be a really amazing experience with your family and your loved ones, however you designed it. But hospice is an organization, which I'll talk about, that may be able to make that happen versus some of the other ways that people die, and will continue to do this way. So that's where I come from with regards to hospice and palliative care. As you can tell, it's a very much of a realistic black and white view. Not everybody has that opinion, but I think it's important to know where I'm coming from, and then also where you may be coming from when you start having questions or plans about your own end of life. Okay, now back to the whole reason why I was asked to come here today. So although by the way, in 2014, I'm a family medicine doctor who in 2014 got board certified in hospice and palliative care because I was the hospice medical director, wanted to be better at this skill. I did 2 years of training at MaineMed as well. So why does our certificate say hospice and palliative care when they're completely different things? They're completely different things, okay? So palliative care, to palliate, right? So palliative care is a specialty in medicine that provides services and opportunities to people facing serious illness. You don't need to have a prognosis when you're getting palliative care. Palliative care are specialists that can come to your home or come to the clinic or come to the hospital. And what we say is that we're the quality of life docs or providers. We don't care what's the matter with you. We only care what matters to you, okay? So although we know what's going on in your life, medically speaking, we're going to come in and we're going to talk about two basic things. One, goals of care. Do you know where you're at? And how are you with what's currently being offered to you in the medical system? And really, do you have other goals in mind? Let me give you an example. The most common goal that people have is, I want to stay at home. But they're being asked to go to the lab 3 days a week, and they're getting chemotherapy 2 days a week, and they're seeing dermatology on Mondays, nephrology is on Tuesdays, cardiology is on Wednesdays, but they want to stay at home. Well, let's talk about that. Maybe we don't need to see a dermatologist. Maybe we don't need to see this. Maybe we can do lab work at home with a home health nurse. So we talk about goals of care, and then we try to get these goals of care documented somewhere or at least discussed amongst family so that everybody's on the same page. We have various types of advanced directives that you can fill out. One's called a POST. We have a MaineHealth, we should have brought some today, but we have MaineHealth advanced directives with most of your providers can have in their office. It's a 12-page form that you can kind of fill out. And you can go into as much detail as you want. I have people that put down what song they want played at their funeral, and I have other people that don't make any decisions. They just fill out the form, identify who their power of attorney is going to be for their end-of-life care. And so palliative care, goals of care, the other most important thing we talk about is what matters to you, symptom management. We're kind of the symptom experts. So whether it be short of breath, whether it be thirst, whether it be pain, whatever it may be, itching, we're kind of the symptom experts. And so we will try to figure out what tools do we have that may help you with your symptom as best we can. And then we try to relay that usually back to the primary care provider. I forgot one very important thing. I am one of several palliative care providers in our organization. There's another one her name is Lori Ann. She's a nurse practitioner. And as of, I think, next month, we're getting some additional support from MaineHealth. We'll be getting another provider into the area as well. So there are other providers that provide palliative care. And so that's palliative care. Symptom management, whatever your symptom is. And it's kind of interesting. As I spend time with my hospice patients or my palliative care patients, it's amazing how much that doesn't come up in the doctor's office. Like, I see 20, 25 people a day. It's amazing how little I ask them what bothers them, right? Or like, what symptom really drives you crazy at home? Well, you know, it comes up usually if the patient will bring it up, but we just come at, in our primary care hats, we kind of come at the visit a little differently. It's a little more time condensed. We're trying to get something done. Where when I do my palliative care consults or my hospice consults, we get more opportunities to learn about the human being that we're talking to and find out where they're coming from. So symptom management, goals of care, is what we do. Like I said, we don't care what's the matter with you. We ask what matters to you, and that's palliative care. Now, you can get palliative care at any point in your life. You don't need a prognosis. Here in this area, all you need to do is have your provider send a referral through our electronic medical system to palliative care, and they'll know how to do that. And then either I or Lori Ann will get that referral, and somebody will reach out to you. Most people are faced or have been faced with a serious illness and they're struggling. That serious illness, by the way, may not be terminal, but it still could be burdensome. An example of this would be something like congestive heart failure, where the patient's going back to the hospital every few months. They can't seem to get on top of it. They're going back home, and they're really tired of that sort of wagon wheel approach, and they really want to talk about, what else can they do? And then, of course, cancer comes up. We have a great oncology service here that uses palliative care all the time. Matter of fact, our oncology service with Dr. Glick, one of their quality measures is that a certain number of their patients with certain diagnoses automatically get a palliative care consult so that somebody else is reaching out to them to talk about their own symptoms as well. So they're very supportive of palliative care. All right, palliative care. different. Hospice. Hospice are services that are available to everyone to provide physical, spiritual, emotional, and social support for end of life. The only thing you need to do to get into hospice is your provider needs to sign a certificate basically saying, this is a diagnosis and it is my professional opinion that this person may have less than 6 months to live. This is where the loaded stuff comes into play, right? First of all, we're really bad. We're really bad at predicting prognosis because we're humans. It's complicated. There are some conditions that we as providers, and someone like myself who's been doing this for a long time, can be pretty accurate, but a lot of times we don't. And so by getting into hospice or by getting the services going, we're not predicting death. We're not giving up. We're just providing additional resources either into the home or at St. Andrews or at Cove's Edge or in the hospital so that we can support the patient and the family. Mainly the family, by the way, mainly the family. They're the ones with the burden, right? How are we going to pull this off? And hospice comes in to help with that. Hospice services include a nurse, usually a CNA, volunteers, a chaplain. Sometimes some hospices have therapists that can come in that can provide things like you wouldn't think massage therapy, right? It's palliative, it helps, makes people feel better. So hospices have a team of people that get deployed to the patient wherever they are, and they give support at the end of life. It is paid for by all insurances, and although we initially predict 6 months to live, you may graduate from hospice. We actually used to make T-shirts that said hospice graduate. It's a pretty tough T-shirt to wear around town, isn't it? Like, what you been through? I went through hospice, graduated, and now I'm out. And so sometimes we don't know. And you can extend hospice out indefinitely if the patient does well, kind of stabilizes. One kind of interesting note about hospice is when you go on to hospice, the only caveat that we have in the United States with regards to Medicare is that you cannot receive treatment for the condition that you're being admitted for in the hospice, okay? This is where the giving up kind of comes into play. If you're getting chemotherapy for your cancer, you can't get Medicare to pay for chemotherapy if you're in hospice. Interestingly, by the way, studies have shown that people live longer on hospice than they do when they're getting full court treatment in a hospital. It makes common sense, doesn't it? If you're at home being loved for and cared for and sleeping in your own bed and getting your own food, you're going to live longer than what they do elsewise. But that's where this sort of giving up idea came from, was that under Medicare rules, you can't get treatment for hospice for the diagnoses that you're being admitted for hospice. So if you get admitted to hospice for cancer, you can still go see your doctor for heart issues. You can come see me for anything. But that is one caveat about that. Interestingly enough, the other thing that we do on hospice when people come on to hospice is we generally stop most meds, okay? You don't need to be on Lipitor if you're on hospice, okay? It's not gonna do any good, right? And I will tell you that one of the most humbling things I see when I'm involved in hospice was we would stop all their meds, and guess what happens? They get better. And as a primary care doctor, it was so humbling, like, what am I doing exactly? I'm making my patients sick. So that's not always true, though. It's not always true. We're trying to do something good. But you get the idea that, if someone's, I heard a stat the other day that the average Mainer was on 18 medications, and that's a lot. And to think that they all don't interact some way or another and make you feel pretty lousy is untrue. Don't go home, stop meds, by the way. Go see your doctor. And anyway, so that's one thing on hospice that we do. We clean up the med list. We try to make life as easy as possible. And we just support people for end of life. So hospice, 6 months or less, prognosis maybe, a team of people that come to get deployed to the home or wherever the patient is. It is covered by all insurances, and we don't know how long that'll be, but you can keep going on hospice as long as you're around, as long as your loved ones need support. Palliative care to anybody involved with a serious illness. We're kind of the goals of care, symptom management experts, and anybody can get palliative care and continue to get all other services available. So I think that was my attempt at warming you all up for someone actually who does go get the job done. And I think want to do questions and answers after or for each subject? Okay, well, I'll tell you what, we'll wrap up this, because end of life care can be kind of, any thoughts, questions that I could answer on hospice and palliative care. Anybody have any questions?
I have one for you. You said, I forget how to word this. You said you don't impart your feelings on the patients. What if they asked you for that? If they said to you, honestly, Dr. Joe, what do you think, what would you do if it was you or your family member?
Yeah.
Are you honest about
Of course. Yeah. So those are two different things. What I meant by my first statement was like projecting out. So there are people who can't wrap their head around dying, right? They'll never get there. They don't want to make decisions. They don't want to fill out trusts. They don't want to fill out advance directives. Let my kids decide. Let my other mom decide. And initially, I would be very, I don't want to use the word aggressive. I guess I would be pushy a little bit. Like, no, you need to do this, this, and this. But then I realized that that's where they're at. And I can never force them to get to where I'm at with regards to thinking of it. So that's my projecting part, was to be a little softer. And of course, as you get wise in your years, like me, you get to be a better listener and just like close your mouth and shut up and just listen to the person talking to you. But, and kind of get where they're at. And then rather than trying to force them into by that. Yes, so I mentioned earlier about those of us who have been involved in primary care particularly, or end of life care, we get pretty good at knowing kind of where we're at, where the patient's at. And of course, I can be brutally honest, particularly with the patients that I've known. I have had the best patients for a long time. I know them really well. And if I know them, and you can imagine some of these old honorary Mainers up in Jefferson and Noblesboro. I know there's no honorary Mainers down in Boothby Harbor because that's the style down here. But up in Jefferson and on, it's like, Jack, yeah, we're close. I think we're close. I think we're a week or two, or whatever it may be. And I only do that when I have a pretty good feeling of it. But once again, one of my neighbors was just in the hospital recently, and he made a turn for the worse. And I told the family, who was always like, Rob, we're trusting on you to tell us what's going on. And I go, yeah, I don't think he's going to make it through the night. Boom, calls come out, family flies in town. He went out fishing with his sons on Father's Day. True story. It's a true story. So we try to be honest. And it's interesting you bring this up. This is a great conversation because when I went on to Maine Med has a lot of residents, a lot of teaching hospital. And we would be in a room of the patient, and there would be 8 doctors, 3 nurses, 4 residents, and the patient. And the patient would or their loved one say, how much longer do you think we got? And we'd go around the room and him and ha, well, we got to check potassium level. I don't know. We got to wait for this test. And I would literally just look at him and say, sir, if you want my opinion, I have to get about a month or 2 to live. Residents are looking at me like, what did he just say? What? He has no right to say that. And I always tell them, if I'm not going to say it, who's going to say it? They're asking you your opinion. If you're wrong, they probably would love that about you as well. So just give them your opinion as best you can, and then hopefully be there to continue on the conversation. I had one of my mentors in palliative care that I trained with. She presented this case, and this case was this woman. The patient was a man, and the wife, to show her love for him, kept asking for more things to be done to him. More things, more interventions, more surgery, more surgery. And I told the palliative care provider, I go, I would not last very long in this case. I would just have to sit with that. I know what you're thinking. This is not a good thing. And then she told me one of my favorite lessons was, if you've never been fired as a palliative care provider, you're doing it wrong. Meaning, there are times where you need to be the one, out of all these other providers, to step in there and tell them what you honestly think, so that may change how they're thinking about things. And I do that in primary care as well. So it's an old community, just in case you haven't noticed. So that's why I got involved in hospice. Any other questions? Thoughts? All right. Jeff Slack, the man, the legend, the myth.
Good morning. I'm going to just follow up on Rob Hunnell just for a minute. My wife's family is from Bristol, and they've lived there, the Knight family, for forever. My wife's grandmother passed. This was probably in, I'm going to grab a date of 2012 or 13 or 14. And Rob Hunnell and another one of his assistants, Stephanie, who was a home health, either CNA or nurse, went to their camp. She stayed out at Biscayne. Rob met with the family. He had a great conversation with my Uncle Stan. He had these antique trucks. And he broke the ice. So when he came in, he goes, "Oh, look, you," and then all of a sudden the tension level went down, and Mammy lived, like he said, a lot longer, and the quality of the end of her life was just amazing. So
Well, thank you, Jeff. I did not know that. That's very nice.
Yeah,
Thank you.
Yeah, Rob. My name's Jeff Slack. Just a quick. My life story is when I was on my way down here, I moved to Booth Bay Harbor in 1988. Maybe you remember when there was a valet service at Fisherman's Wharf downtown. I worked with Kenny Goslin and Jim Savory. If you guys have lived here, a long time. I rented from Charlie Hano on Chapel Street. So a lot of reflections when I was driving down here today. And I also played in the men's basketball league here, and that may have been the last time that I was at the Y. The Y now is absolutely beautiful. Where it's came from back then today is just wonderful. Enough about that. I worked for my department is access to care. Cindy Wade said Care Partners is maybe what some of you might remember it as, but it's morphed into what I refer to when someone comes into my office to meet with me as buckets. I have 4 or 5 buckets, and I do all kinds of different services, and I can usually help anybody that walks through my door with something. The first thing that I was going to talk with all of you folks about is the Medicare Savings Program. Are you familiar with that program at all? Some of you, probably all of you, pay $174 out of your Social Security check to pay for your Part B premium payment. Well, the Medicare Savings Program is absolutely wonderful. If you are income eligible, based on what your income is, I can assist you in leaving that money into your Social Security, meaning that you get to keep what I refer to as your whole Social Security check. There's a program called Quimby and another one called QI, and I would love to talk with all of you about it. I've got the guidelines up here that I'd like to get to all of you, because this is what's really exciting, is the governor has expanded the income levels dramatically. So if it's something that you folks would qualify with, that I could help with, I would absolutely love to, assist in doing that. The next thing that I was going to talk about, which some of you may know, are you familiar with what's called the donut hole? If you have Part D prescription coverage, where you go into the pharmacy and your Eliquis has been $15 or $25, and then all of a sudden you ask the pharmacist, why is it $65? And then this is really frightening. The next time you go in, it's $500 or $600 or $700. I have a program which is called Med Access. So if you fall into the donut hole, more times than not, what I can do is do an application directly with the pharmaceutical company. I think Eliquis is Squib. Anyways, whatever company that it is, if it's insulin that you're on that becomes too expensive for you to afford, I can do an application directly with the pharmaceutical companies themselves. And with Dr. Hunnell's help, what you do is you come into my office, we print an application, I fill it out. If Rob is your primary care physician, the Brianna is his MA. She and I email, back and forth. The application goes to Dr. Hunnell. He fills it out, sends it back to me. With your income, I send it to the pharmaceutical companies themselves. And more times than not, the medication at that point going forward is free. And the medications either get delivered to the provider's office or directly to your homes, which is really wonderful. Most inhalers, for example, don't go to the doctor's office. They get delivered right to your house. Any questions? sometimes I get going. I'm very passionate about what I do, assisting folks here in Lincoln County. So slow me down if I talk. Yes.
On that income level, is it just income that comes in, or does it include all assets?
It does not. Thank you. I was remiss for saying that. The asset test was taken away from this program in January, which is, thank you for bringing that up, which is huge, because people for years never qualified for it. For example, I'm just going to grab a number. A couple gets $2,500 or $3,000 a month Social Security, but they have a retirement account. But really what they're doing is they're not really touching it. They might get into it for like $5,000 throughout the year to pay for things. But that test, that asset test, used to count for the Medicare Savings Program, and it doesn't anymore. So it's based on, I saw the smile, it's based on what you receive each month for income, whether it be Social Security, retirement, things like that. Any questions about the PAP process? A lot of times people, it's the patient assistance program for medications have questions. So go right ahead.
The amount each month that is based on, is that per couple or per individual?
Per couple. Yep. But there's higher income guidelines for couples. So that's a really good question. Yep. The next thing that I was going to talk about is this room, and I'm not. If somebody, what I'm finding more and more, people are coming into my office are wanting to retire sooner than waiting for Medicare at 65. I'm a navigator for the marketplace, which people have called Obamacare, but it's insurance. That when you leave your job, if you have health insurance from a employer, a lot of times what I'm hearing from folks is, I would retire if I could get health insurance. Well, that's something that I'm just letting you all know, that if you know folks or if you are in this situation, we can sit down and what I refer to it as kick the tires. I have a program that I go into, I put your income in, see what the cost of health insurance would be on your own. Sometimes it's less expensive than even what they were paying for I'm working for an employer. And lastly, what I was going to talk about today is there are people have health insurance and they have very good health insurance, but there's still co-payments, deductibles that sometimes need to be met. And those can be costly, sometimes as much as, a couple $1,000s a year, depending on whether you go to the doctor's office. I have a program that when I first started working at Lincoln Health and MaineHealth has picked it right up, which is called free care, meaning that if you're income eligible and you have these bills that are after what your insurance covers and doesn't cover, I can meet with you, see if you're income eligible. So let's say that you've got all the insurance and you've got, you don't qualify for the Medicare Savings Program, but you still have bills. So there's, like I said, it's one of the buckets that I can put people into as far as helping with the cost of medical cost. And one more thing, maybe you folks are familiar with Sean Lewin down here at the mall. He has where he's able to give away or assist people in getting durable medical equipment. I do the same thing up in the Aerosmith building. So if you know folks up in the Damascotta area, or if Sean doesn't have it, I'll give you my business card and you can reach out to me, and I can provide you with walkers, wheelchairs, medical beds, lifts, Hoyers, anything that someone donates to me, I kind of keep under wraps and then hand it out when needed. That's it from That's it from my point. Does anybody have any questions?
Since Jeff was so nice to introduce me with you stay standing.
You
We're
got it.
done. I think we're done here. Jeff is a perfect example, and his department, by the way. He didn't mention Sandy. I don't know who else.
Gosh, and
We all
Kendall,
we all
sorry.
seem to have women around us to actually make things happen, and then we get to come do the dancing,
so
and then behind the scenes, Sandy. But Jeff has always been, and his department's always been the go-to people to get something done. This is a walking example of small town medicine, small town organizations trying to get it done. Because just in case you haven't noticed, the healthcare system has gotten a little complicated. Did you try to get your med recently from Walgreens? It's complicated, right? But we're desperately here, and as you know, we had St. Andrews, then we had Lincoln Health, and we keep getting bigger and bigger. But Jeff and his department is a walking example of, Jeff, whenever I have a patient come and ask me for something, whether it be a wheelchair, or I want to retire at 63, or I can't afford my inhaler, I open the door, I scream at Brienne, I call Jeff, close my door, and his department gets it done. So an example of getting things done that people really want, like all the things you were just talking about with regards to the donut hole and how do I retire early, and all that is what people are talking about. And he's a good resource, and his department is a great resource, because a lot of times in our offices we don't have an answer.
No.
I don't know where the wheelchair is. I don't know how to retire early. So anyway, sorry.
And definitely not
Summing it all up.
right. Not to pat myself on the back. People have reached out to our doctors, and the first thing that they say to them is, "Have you called Jeff?" And it could be about housing, transportation, and what's neat is because I have over the years built up so many resources. You're right,
Yeah.
Brienne. She's a saint.
Yeah, and you got the same team over there. So,
Yep.
any last minute thoughts? Yeah, here we go.
So we just called you?
Correct.
Call Jeff.
No.
He's got cards right here.
Let me give you.
We just hand them out like dollar bills, Jeff. Just hand them out.
For example, Dr. Alamo said to me, he goes, "I have a patient coming in at 2." And of course we had permission, and he calls me up and he said, "Jeff, I need an inhaler." And we've tried for example, ProAir, Brio, all of them. Which one do I need to tell him to come to you so that he can get it for free? But that's the coordination that we have with the doctors, is that they, Dr. Worthing up in Damariscotta, he was stressed beyond belief with this young man who needed Humalog and Lantus and who didn't have health insurance. He called me, I printed the application over the phone. The patient swung by, signed it. I sent it to Dr. Worthing. Dr. Worthing sent it back to me. So this is all in a matter of 12 hours. The insulin was at this young man's house in 2 days. But it's these guys that make it happen, because what they do they let me run, with it, and it's just it's the program that Access to Care offers to Lincoln County is really cool.
Great question, though.
Yeah, last month I was at the senior center supper that they have at Wiscasset, the community center. They have a supper on the first and third
Wednesday.
So,
Yep.
and there was a couple there, Kay and Gary, and they were saying, she was going on elevating, oh, Jeff start this, and Jeff that, and Jeff this, and the next day I get an invitation to come to this, and I said, okay. Clearly I was meant to be there.
It happens.
You may be getting a call from a couple in Wisconsin.
Yep. No, I've gone. But I was I was a selectman in Wiscasset for 8 years, so I have a great feeling for our senior center up there. So nope, it's wonderful.
I don't live there, I just go there.
No, I'm glad you do. And do they
Take advantage of the potlucks.
And do they still play
do a potluck
cribbage
every
on
night?
Thursday?
You probably do potluck every night for free.
Right.
Just got to travel a little bit.
Yes. Yep.
Did you have a question? No? Any other questions? Revan is back here. She works for, I think, marketing department, and not marketing. Philanthropy.
Yes.
Talk about the system getting complicated.
No,
we don't have a marketing anymore. That's philanthropy.
Yeah.
Yeah.
Development. is what I
Development.
call-
It
Yeah.
used to be development.
Right.
Is that gone?
No, I still
We still
call
got
it.
development? Okay, it's all one. It's all one. They get the job done. So if you have any questions, she'll be on the way. And I'm up here for any questions, just in case you don't want to speak up.
Could you talk a little bit about the 24/7 pharmacy that we have through MaineHealth?
I would love to talk about the 24/7 pharmacy through MaineHealth.
Talk about it, or
I don't know anything about it.
Jeff?
I know that it's wonderful. If you reach out, let's say that you're using Walgreens, or if you switch your meds to the pharmacy, they'll deliver them to your house, or to the doctor's office, or however they need to be done. And it's really it's what I'm hearing is the cost is a savings using the Maine Med Pharmacy over our local pharmacies, but I don't know.
Is that available to everyone?
A lot about it.
No lines at Hannaford.
Right. Right.
Now you're talking.
Right.
Now
And
you're,
we also have we have a pharmacy at Penn Bay too, that
Correct.
mail order medication as well through Penn Bay.
Yep, it's wonderful. Yep.
I just write the prescription and tell them the good luck. That's all I hate.
Right.
I have used the Maine Med, but I thought that was only employees, but that sounds like good. And there's a new pharmacy in Wiscasset.
There is.
Genoa?
Right by Wiscasset Family Med. I still call it Dr. Kitfield's office, but right on Water Street.
Yeah. We have struggled in Damascata significantly with pharmacy coverage, and I always like it when these like Nathan's came, and then this Genoa one, because there's kind of mom and pop stores that they generally get things done. So that's good. Sorry about that. Is there anything else you want to bring up? No, that I don't know about?
The pharmacy at Maine Medical in Portland, is that what you're talking about?
Is that where
Yes.
they're based out of?
Yes.
Yeah.
Yep. And like Cindy said, there's one at Penn Bay as well.
And it's more reasonable than.
That's what I'm hearing. I get medications for folks for free. I really don't deal with pharmacies, so I use Nathan's down here in Booth Bay, but I don't.
I have that.
Yep.
Yeah. Speaking of MaineHealth, by the way, you're going to see some name changes on. I was just asking them about the pens and the paper. I guess is all going to be changed over. And I'll tell you, our although change is sometimes tough, everything that we've been seeing in the way of organization, 24/7 pharmacies, additional help for palliative care, I think it's going to end up being really some great opportunities for efficiency, better value of care, and I think in the long run it's going to be better to have the strength of sort of MaineHealth and its organization behind us, and despite some change is hard when you've been doing the same thing for however long you've been doing it for. But I think you're going to see, and that may help some navigating, that may add some navigational issues, because who are we calling now and what's the order to go to, but we'll work it through. So anyway, a positive note about
To
MaineHealth.
follow up what he said, the teamwork between MaineHealth is wonderful. Let me just give you some more information about me. I always used to carry 360 hours of PTO. I never took time off because it literally, I answered the phone. I just took a 2-week vacation this last year for the first time in years. So he's right. The coordination between MaineHealth now, Lincoln Health, Penn Bay, Midcoast Hospital, it's amazing. It's great. It's great teamwork from us all the way up to the providers.
Yeah. All right. Well, thank you very much. We'll be around. Not.
Hager Enterprises, a paving and excavation contractor specializing in all sorts of site work, utility installations, and road construction since 1987.
When Tidewater Telecom built Lincoln County's first fiber-to-the-home network in 2011, we knew we were starting a project that would take years to see through. 9 years later, we are proud to have connected more than 2,000 Lincoln County homes to our blazing fast open fiber network.
but that hasn't dimmed our vision to connect all of Lincoln County. Learn more about the power of fiber optic internet at tidewater.net.